The Australian Atlas of Healthcare Variation put out their third atlas, and finally we are starting to see falls in antimicrobial use in the community. But you can see in this box on the right how our overall usage in our community is still very high. And so this is actually one area where I think we need to be looking at in terms of how we reduce total usage. The other thing we have when I have travelled the world for stewardship is to realise that we have an incredible legislative approach to antimicrobial stewardship which far exceeds the efforts internationally in many countries. And our accreditation standards not only apply to the public, but they apply to also the private hospital system. It has been there for 5 years now. We're on to our second version. I've been involved in the Canadian design of their accreditation framework, and it will be following closely to the Australian one. In fact, they've used a lot of the Australian resources to look at how to approach it. But we also have national antimicrobial guidelines. The therapeutic guidelines have been around for many, many years, over 20 years, and they were our de facto national guidelines, but they have now been formally endorsed as part of the armamentarium of our prescribers in community as well as hospitals. I think the other thing which has played into our advantage actually is a slower penetration of electronic medical records. I know that's a bit counterintuitive, but I'll discuss that a little bit later about some of the unintended consequences of electronic medical records. It's not always, you can't assume that having an electronic medical record will improve quality of prescribing, and I'll discuss that later. However, we do have significant geographical challenges. We are seeing the emergence of approaches to delivering stewardship in rural and regional, particularly with Jacqueline's work, models for such as Tom Schultz with the Golden Valley program, and we have challenges with Indigenous health. The other fortunate thing, which is really interesting when you compare our prescribers and our clinicians, is that we have a huge number of ID physicians per capita and a very high number of clinical pharmacists per capita. And this has been of interest to my international colleagues when they're looking at implementing programs, because lack of some of those frontline staff to deliver stewardship really makes it very difficult. There is an OECD report. This was a report produced in January, tackling wasteful spending on health, where they did actually look to see how we, the benchmarking of rates of inappropriate use, this was not a NAPS type methodology, but you can see we are sitting quite low on the range of appropriateness in hospitals, but actually we're really outside, really high up in inappropriateness in long-term care and general practice. And I think both of those things are well and truly highlighted in our aged care NAPS and our GP NAPS. And these are key areas where we need to improve our quality of prescribing. The other interesting process to have been involved in was the joint external evaluation. And that is a program that is coordinated in WHO member states, and it relates to looking at how well set up countries in responding to emerging issues and threats. Antimicrobial resistance is one of those threats, but there's biosecurity and all sorts of other threats that they look at. And it's a very, very comprehensive process. There was a focus in Melbourne, and it occurred over, I think, 2 weeks, and Royal Melbourne was one of the sites where they visited. And they really looked in incredible detail as to all the elements in place. And this report, the mission report, all these reports are available for countries where they've had a joint external evaluation, and I'll show you how Australia fared. So when we look at antimicrobial resistance, and in fact other elements like equality of the legislation, advocacy, zoonotic diseases, biosecurity, we actually rank very, very highly compared to other countries. And these were the areas that they focused on for antimicrobial resistance. So is there methods to detect it? What's the quality of the surveillance? What about healthcare associated infection and control programs, and then antimicrobial stewardship activities? I was actually a little bit disappointed by the 4, to be perfectly honest. But I think this is a fair representation, because those of you who are involved in antimicrobial resistance and valence, we know we have some strong elements, but currently voluntary and separate groups providing data to a national surveillance program. There's no strong coordination at the moment, and there certainly is very little in the animal space. This was a flag, obviously, and I think this is really important. This is something we've talked about a lot in NCAS. So interoperable, interconnected, electronic real-time reporting systems, really the holy grail of setting up a national surveillance. This is the ranking, and Japan pipped us at the post. And I guess the point to make there, which I wanted to highlight, there was very little about the implementation of stewardship in their report. You didn't really get a strong sense of what they actually did compared to the Australian report, which is really detailed. But what was very impressive is that they have acquired a remarkable platform for surveillance, but also they have incentives, financial incentives for both prescribers and hospitals to implement stewardship. And this, I think, certainly in my experience, trying to establish programs, functional funded programs, is going to need some sort of incentive process, because we've reached a plateau in terms of our appropriateness in the NAPs over the last few years of around 72%, and how can we get it over? There needs to be some other nudge or some other driver to improve appropriateness even more. The implementation plan for our strategy is actually being revisited, and this was the one that was put out in 2015, and the new strategy has been written right now, and largely the key objectives are actually going to be very similar, but it will be reflecting back on what we have achieved in the last few years. And I think in my mind, particularly in terms of looking at antimicrobial appropriateness of use and judicious use, I think at the moment we're still in a situation where many of our data collections are actually voluntary. NAPs and ACT-NAPs are voluntary, but are nudged by the fact that they're recommended by the accreditation standards, the type of surveys to be done. We still lack interoperable systems for reporting. Despite our strong government support for this program, we're in this quagmire of an incredibly complex system where hospitals are funded by states, the community, general practice and aged care is funded by the Commonwealth, and we have multiple bodies, multiple committees, multiple lines of communication, and I'm always actually amazed that things can actually get to COAG to change what happens, because really there's lots of players and there's more players coming along and more committees. So the coordination of the decision makers, I think, is something which is, I think, a real challenge. And obviously for those of us working in this space, there really does need to be much more linkage between the animal and health space. And you could essentially say at the moment that aged care and general practice really do lack stewardship in the way that we would recognise it. So my position has always been that we need a body to oversee AMS across the sectors. We don't know about targets. Many countries have set targets, but there needs to be some, I think, performance measures around the types of either appropriateness or types of antimicrobials in use. This is a piece of work that NCAS has been doing, and this was part of the list of the stocktake list in the last plan. And this is where we have looked to see how can we improve interoperability across our NAPs platforms and to support electronic systems. And we have developed and designed a cloud-based universal indications list, and this has gone through an extensive period of development because of particularly with our work in guidance, understanding indications of use, understanding the types of indication therapeutic guidelines, as well as indications specific to different countries and different groups, such as children and tropical areas. We have established and SNOMED coded a list. This is an international coding standard, and this will allow data flow particularly across the NAPs for our reporting, and can also support indications within EMR systems. And it is something that we're talking about with the digital health agencies. It is part of the National EMR plan, and now it's sort of thinking about how we can implement that formally. This is what it looks like, where we have different countries can have, it's the same list, but different countries can have their own aliases and tags. We have a central committee that convenes regularly to review requested indications. So yesterday we had a teleconference with our Canadian colleagues where they're doing NAPs in around 40 hospitals, and there have been a few requests for particular indications that probably are what we have, but there might be a cultural way of expressing those indications. And our central committee in NCAS, which is multidisciplinary, will discuss whether or not to add it or amend it, and we'll work with the Digital Health Agency if there's SNOMED code to add that code. We have had, NCAS has had the opportunity to have some leadership here, and there are two core pieces of work which are really important. One was international publication that I was involved with. This Celine Puccini's from France, but we have representation from the UK, from Ramna Laxminarayan from CDC, South Africa, Scotland, Netherlands, Switzerland. Alison Holmes, the sort of key clinical leaders, and we published a paper really trying to estimate the human resource assessments. It was very much hospital focused, I admit, but at least it was the first step to say, well, we actually need people to do it. The second thing was to develop a consensus approach on what are the elements of a hospital antimicrobial stewardship program that would be applicable to low and middle income countries as well. And in the meantime, we have been involved with quite a lot of activities with World Health Organization. We developed an implementation manual, designed a 3-day workshop. Kirsty, I and some of our team are technical advisors for training education. We had a very interesting process where we were asked to revise a training manual produced by another group, and it was contextually quite inappropriate, we thought, for low middle income countries, and recommended to the WIPRO group that we would actually like to do some in-country visits to look to see how achievable or feasible these training packages were. So we paired up and visited Laos, Mongolia, Vietnam and the Philippines, and did in-country assessments on how they were actually doing stewardship and the significant limitations, which are too numerous to mention, but certainly very, very poor laboratory capacity, and any sort of sense of meaningful surveillance was largely absent in many of those countries, although some countries like pockets of areas in Vietnam were really shooting ahead. Nevertheless, there were incredible clinical leaders when each of those countries, that if they actually had the structures and resources, we had no doubt that they would actually be able to do it. So providing them with sort of meaningful advice on how to approach their health department and what sort of business cases went through was really important. And unfortunately with the Philippines, they just had funding for their AMR program, and they were going to propose one infection prevention practitioner for every 100 patients, but had completely left out clinical pharmacists. So when we went there and said, well, where are the clinical pharmacists? So we don't have any clinical pharmacists, we have no training program. It was sort of a penny drop that, oh, shivers, we might have forgotten a key group of personnel for implementation. So in the hospital in Australia, I think some of you might have seen this slide already, but look, it takes time, and this is 20 years of our work here at the Royal Melbourne. This is pre-2008. We had already built and implemented guidance, and guidance had already gone to several hospitals in Victoria. The Austin had ideas. John Ferguson was doing some work in New England. But in a hospital, the structure around stewardship really was very limited. The therapeutic guidelines, of course, were already in existence. And one of the first things that happened was that I had the opportunity to have a cup of coffee with Chris Bagley, who was then the Chief Executive of the Australian Quality Safety Commission. And he came across to talk with me about, well, what do we need to do? Because the Commission had thought we need to be starting to look at AMS. And I said, well, we need to really get the key stakeholders around the table. And he said, oh, okay, we can pay for a working party, that's fine. Who should be on it? We formed a working party. And really the first piece of work was to look at the literature about what was required for stewardship. And this was the first book, the AMS book, hospital book. And it really, I think, was an amazing achievement. It was a really fantastic committee. We worked really hard. And that book actually was used by many countries, including Germany, in designing their training and implementation for stewardship. Following on from that, it was really the essential requirements out of the book that informed the very first standalone stewardship accreditation criteria. There are challenges with stewardship being shoehorned into infection prevention, because if you really think about stewardship, it crosses public health, it crosses infection prevention, it crosses medication safety. And Canada, for example, have put their stewardship accreditation within medication safety. So there are pluses and minuses there, but obviously some of the key personnel doing stewardship are actually those involved with medication safety, so it's something to think about for the future. And then the other piece of work that we did was actually establishing the first ever national survey that really did have meaningful information about appropriateness, and I think that has really put us well and truly in front of many other countries in terms of understanding exactly what's going on in their prescribing. And finally, it is worth mentioning this clinical care standard, and it is different from the hospital accreditation standard. The hospital accreditation really is a series of activities as hospitals need to do. The clinical care standard relates to how a person prescribes. And it relates to whether their own prescription for antimicrobials meets minimum standards. This is multi-sectoral. This could apply to humans across aged care, general practice hospital. It could even apply to veterinarians actually, because it's the core principles of how you actually prescribe. So these standards have been updated and went into play middle of last year. And as opposed to the sort of the fairly kind of generic, more basic recommendations, they have become much more granular now. And we are now really honing in on actual activities that need to be undertaken, including restriction rules and approval processes, measuring elements of the clinical care standard, and some of those are very patient-centred. So how do you measure whether how you are talking to your patients about how they need to take their antimicrobials? Do they understand why they're on a particular antimicrobial and what do they need to do when they get home? How do you measure that? And so here at Royal Melbourne, we have engaged our consumer representatives to do some of that work so they can actually talk to the patients to measure whether or not the doctors or the prescribers are actually doing some of these things. We continue to focus on appropriateness, which I think is really important, and not volumes of use, because appropriateness needs to be relevant to the type of patient and the patient population. And this year there was an additional requirement from the Commission that we needed to look at surgical prophylaxis, because surgical prophylaxis is the most common reason for antimicrobial prescription and it's all the worst done. And so that's a really... hopefully that will drive some more activities in that space. NAPS is something which I am actually really proud about, because it really was an iterative process which started off from a very simple survey with interested people. I think it was 8 hospitals at the very start in Tassie and Melbourne, then moved on very quickly with our contacts and colleagues to be I think it was 8, 32, 76, 150, now it's almost 400 hospitals each year doing the survey. And it really is meaningful, because there are few countries that can hone in on, well, exactly how are you prescribing for community-acquired pneumonia? Which are the most inappropriate antimicrobials you're using? And that data can be directly fed back to therapeutic guidelines. So when one of the NAPs showed that azithromycin was the second most common antibiotic being used for hospital-acquired pneumonia, we were able to quickly feed that back to therapeutic guidelines, saying, look, you need to be specifying that macrolides are not required for patients with hospital-acquired pneumonia in the therapeutic guidelines. So that loop back to the guideline developers with this data is really important. And it is being used to support both hospitals as well as the public reports, and really identifying key areas. So We have looked at the difference in quality prescribing between rural and regional. Not only do we see a gradation of appropriateness going down as you move further away from principal referral hospitals into rural and regional, quite significant fall in appropriateness. That inappropriate prescribing for sepsis, for example, that will translate to poor patient outcomes and increased mortality. This is meaningful data to demonstrate that, and this is really important for the sepsis programs, which I think is lacking and should be under stewardship. Our main, not competitor, but the other group or the other survey program, which is in use, funded through bioMérieux and coordinated by the BSAC group, is the Global Point Prevalence Survey. It's a little more complex. It does include more microbiology data, and we have focused very much on trying to get data which is meaningful, and that's where we're very much focused on the indications list as a key requirement, and the lack of granularity of actual indications within the Global Point Prevalence Survey is an issue, and the type of reports are really, our piloting of it here has indicated that it really doesn't meet the requirements for our Australian population. And it's very interesting working with Canada, for example, where some sites are doing global PPS and some doing NAPS, and we're starting to have sort of more discussions about how we can look at making sure that perhaps there are some areas in the NAPS that we need to look at in more detail. The other area where we have shown really great leadership, and this I think we need to put down to the energy of Jason Tribbiano. So he was one of my PhD fellows. He was our fellow at Peter Mac, and it was really there that he dove into this area of allergy labels. The NAPS evaluation of the NAPS data showed that almost 1 in 5 Australians have an allergy label, and even higher in cancer patients. And what that means is if you have got inappropriate allergy labels, that directly leads to high use of broad-spectrum antimicrobials and longer length of stay and poor outcomes. And in fact, if you have an established program such as oral challenges and skin prick and delabelling, you can actually delabel more than 80%. In fact, you'd probably say almost 90% of patients can be delabeled quite safely. And what he has developed is actually a ID physician stewardship-driven allergy delabelling program, which has been incredibly successful. And what that entails now, this is well in train at Peter Mac in the Austin. There we have a nurse practitioner who reviews all patients with an allergy label on the ward. Where possible, if they meet the criteria, they are challenged in hospital before discharge with appropriate communication to the patient's GP and to the electronic medical record. For those patients who require further assessment, they are sent to an outpatient clinic where their first visit involves history taking, skin prick testing, and then they're brought back for a challenge later on down the track. And we also have novel methodologies to look at those patients with the delayed adverse reactions, those serious Stevens-Johnson's and other very serious rashes, where we haven't had very good in vivo or ex vivo ways to assess patients whether or not they can be delabelled. And that is an area of ongoing investigation. And Jason is actually leading a Better Care Victoria grant to further establish the systems approach to that. There was a publication, again, by Celine and her group at XMed, trying to look at what was actually in place in hospitals across European hospitals. And I think they had 14 countries actually that did this survey. And you can see that compared to Australia, there really was quite low levels, surprisingly low levels of things that we would take for granted. Presence of an AMS team, an AMS program, even local guidelines, pre-authorisation. So here I think we can say that I think because of our accreditation framework, I think we are really well and truly advanced compared to Europe. I need to mention this massive online open course developed by our colleague Dilip Nathwani in Dundee. this is actually an incredible achievement. He's also done an online training course for nurses for stewardship, and that is now being translated into other languages, and is really an amazing resource. And it is done every now and then, and look out for I think I do tweet it when they're about to open the next course. It runs for about 6 weeks, and if you haven't done it, I'd strongly recommend. But it is sort of on the more basic end for those of you who already do it, but it is definitely worthwhile doing it. What about the US? Have we learned anything from the US? Well, I was certainly, my whole journey, my entire career was triggered by a New England Journal paper, this one here, which was developed at the Latter-day Saints Hospital in Utah, and it hit the New England Journal, and it was so cool. It was a decision support system that made case-based probability recommendations for antimicrobials for conditions with different options and dosing, and I just thought it was the best thing ever. It was written in its own language and was not transferable, and in my early days as Rhona McIntyre, we tried to inquire whether we could get that for the Royal Melbourne. Instead, we had a drug rep come out to say, well, you can buy the data dictionary for $750,000 US. And that program, many years later, a bit of it has now become Theradoc, which is actually a third-party infection prevention surveillance program, and does do some stewardship. I think it's more used for infection prevention. And and then after that, Rhona and I wrote a grant. We got the grant for Advise, which is the ICU tool that I developed, and that went on to Guidance down the track. So it is still very influential for me, but not really transferable. The second thing was that the US did actually come out fairly early for recommending stewardship programs, which is good. The US subsequently have really gone on to focus on ID physicians as being the key drivers, but I would contest that. I think we need to think about stewardship in a much broader framework than ID physicians. It is really about pharmacists, nurses, establishing stewardship leadership in other domains, and not relying on ID physicians, which incidentally are sometimes the worst prescribers, actually, for those of you who do rounds. The other thing which has definitely influenced what we're trying to do is their approach to information technology, and I think this has been a profoundly negative influence. So the US established this meaningful use program in 2011, and the aim was actually about to drive better funding and billing, because really the American healthcare system is really very much driven by money and rather than quality and safety, and they poured billions and billions of dollars to try and put these systems like CERN and EPIC and other systems into American hospitals without really thinking about quality of care, to the point that it led to huge amounts of dissatisfaction and fatigue. Their concept of front-end alerts and drug-drug interactions and other alerts has led to several white papers which have all come out with the same conclusion, that if you have pop-ups in EMRs, they will be ignored. 90% of alerts are ignored. So you cannot be using alerts to drive better prescribing. In 2018, realising that some of this was massively failing, they moved to say that they've renamed the program to Promoting Interoperability. The trouble is that many of our chief executive officers think that these systems are the best things since sliced bread because they actually will generate lots more income. The trouble is their culture and practices are very different. So in America, there are physician assistants and other ward clerks that actually do a lot of data entry, that actually write up prescriptions, and that just doesn't wash in the Australian healthcare system in terms of the legislation. And so it is a big issue, and all of us who are involved in these systems can see that while they are amazing in terms of representing and capturing stuff about the patient, it can be quite complex for those of us involved in quality and safety. So the class group do actually produce some really interesting reports. So does the Pew Trust, and they're worth looking at. And they did a publication which I think is really actually interesting and really fits into some of the stuff that we talk about in our years and years engagement with guidance, is what users actually want, because they want to be able to control their own decision support and their own rules. And so this was a report that compared both in application AMS as well as third parties, such as the Theradoc that I mentioned, and Walters Kluwer and Vigilange is another one. And really satisfaction with these things needed to reflect that people can not have to go back to IT to get rules changed, that the rules can be flexible, that they want interventions that are going to be high impact, that they need to be able to get good data, they need to look at metrics and dashboards that are meaningful and to be able to drill down into their own data, and that whatever they have, they're going to have strong support, so it's not just sort of implemented and they go. And a good example of that was Theradoc, which grew up in Utah but was adopted by a Nebraska medical centre, which is a large hospital, 624 beds. And they looked at what impact did Theradoc have in that hospital in terms of workload with the stewardship program. And they could see these were the type of alerts that the system did. So prompted for flu vaccination, if there were 3 or more drugs, if there's a drug-bug mismatch, if there's redundant anaerobic coverage, there's vancomycin use or positive blood cultures or no positive blood cultures. And what happened was that there were huge numbers of alerts, lots and lots and lots of alerts, but only 284 interventions made. So one could argue that with that type of system, really a small proportion of the alerts are actionable, and it actually is a huge waste of time sitting there reviewing them because they're sort of generic rules. And this highlights the fact that the way we do stewardship in Australia is much more nuanced. It's much more nuanced because we triage what we do. A lot of us, the way we do, particularly with guidance in many of our hospitals, is to look at who is on what and why and use that as a decision point for reviewing those patients rather than sort of these generic pop-up rules. And we know some of these types of activities have been presented to us by the EPIC program. 1 or 2 might be useful. It would be useful for the stewardship team, I think, to know if there is a blood culture positive MSSA, because we know that patients do better if they're seen by ID earlier. But we would question whether we want sort of random alerts constantly generating. In Australia, as I said, we were late adopters of electronic health records, but we were very early adopters of restriction approvals, and that has obviously garnered interest with our international colleagues. And there are a number of systems in play. Guidance and Easy are the 2 most common ones, obviously. We are now in sort of over 70 hospitals in Australia. And this was our work with the SASI team in New South Wales, which includes Prince of Wales and St George's, Sydney Children's, where they integrated guidance into Cerner so that it generated very high compliance rates, obviously, because it was a mandatory to get approval, but very, very importantly, by integrating it, we continue to see an increase in appropriateness of prescriptions. And I think that is the holy grail, to demonstrate that having approvals and restrictions and post-prescription review to support that process and auditing will improve quality of prescribing. So Australian hospital AMS programs, we have seen many hospitals move to mandatory approvals. We did a couple of years ago now, Barwon, Austin, and it actually certainly increases your rate of approvals. It doesn't really reach, in a paper hospital anyway, it doesn't really reach the sorts of rates, but we've found that even with 70 to 80%, you still can get a really good feel of what's going on. The other element, which definitely requires resourcing, is the post-prescription review process and the ability to evaluate the performance of the services. And this is always a challenge, how we get feedback, how do we get our data back to the decision makers in the hospital. It's an eternal challenge, particularly in rural regional where there are visiting VMOs. And so what we are seeing is what are the models that are going to be working in those sites and how can we influence change. And electronic medication management, really many sites are trialling different things and thinking about how they can ramp it up. Jacqueline's work with her PhD really has been very important because it was able to demonstrate that there are actually lots of different models for doing stewardship, and we are seeing some really great things happening. Statewide program in Queensland. We see some hospitals where they have actually got a local ID expert, which they're very lucky to have. We've got telehealth supported rounds, visiting physician models, pharmacy-led models, nurse-led models in New South Wales. Some have ad hoc phone support. This is probably the weakest one. Clearly there are even medical legal issues there. But the overriding theme is that the hospitals need to feel like they have ownership over the program and that they have adequate support to help them with it. In the US, the CDC have put together core elements, but this, the challenge, as soon as Trump got in, actually, this wasn't ever really actioned. So it's kind of, they call it, Marion Caney called it, it's in regulatory purgatory. And the challenge in the states is that there is no national anything. So every state is their own state in terms of how they implement their healthcare programs. There are some Medicare things that cross-cut, but that's only a relatively small proportion of patients, like 10 to 15% of patients compared to all. A lot of it is through these private programs. And so while we're seeing some improvement in the core elements, I think when you deep dive into what's actually happening in the States, it is really quite a way behind. And reflecting back again, coming back to my original point is about implementation science. It's just really something which we're seeing focus on, and all our fellows at INCAS are actually doing, including the vets, are actually doing qualitative research to understand drivers of prescribing and behaviour. One of the leaders in this really is Esmeta Tirani and Alison Holmes' team from Imperial College, and they were, this is a great paper. We love this paper. Was a systematic review of behaviour change strategies. I think it's still stands out as a really key paper, and they've gone on to do some really interesting studies on prescribing etiquette, which we absolutely know is a key area, as well as differences in how surgical and acute medical teams are prescribing. And in fact, Courtney, one of our fellows, has been doing, I was involved in the qualitative interviews with the surgeons, and I can't wait for the paper to come out because there's some of the best quotes I've ever heard. Hilarious, particularly comparing colorectal surgeons and plastic surgeons and, yeah, neurosurgeons. Very interesting. The other person who I think is a national leader in this space, or their brother and sister team actually, so Alex Broome and Jennifer. Jennifer's an ID physician. Alex is a sociologist at University of New South Wales, and they also have been doing some fantastic work. And again, this is very culturally sensitive to the Australian healthcare. And this is one of Alex's papers where the surgeons were talking about, surgical registrars actually talking about gentamicin, ferriidicin, betadine blessing as to why these things were being done with no apparent clinical evidence behind them. And so again, they're definitely worth reading. In aged care, we have a rapidly growing and ageing population. This is Australia in the black line. The sheer volume of aged care and the population of our aged care in aged care homes, which again is unique. So Australia has a large proportion of the aged care in homes, and this is very, very different to Asia, where there are really no aged care homes. I think Japan is the other place where there is commonly in aged care homes, but it is very interesting, the sheer numbers. And this is why it's no surprise that we have the Aged Care Commission now on provision of care for our aged care population. And the ACNAPs really, I don't need to go through it in detail, but pretty kind of shocking figures. So over half prescriptions weren't associated with any symptoms in the infection the week prior. 1 in 4 prescriptions had no indication charted. Almost a third of prescriptions were charted more than 6 months prior. Cefalexin was used for 1 in 5 indications. Very few met recognised definitions for infection, and there was just no review and stop date. So this really highlights clear areas where there needs to be action. Around about the time that I did the talk, there had been a publication by the team, Philip Howard and his team from Public Health England, Diane Ashrew, who many of you have heard of, Elizabeth Beach, did their first survey in 2019 across all 4 nations in the UK, and they used pharmacy data. And, it really was interesting here because you were seeing much more narrow spectrum prescribing in the UK. much better than in Australia, where cefalexin and amoxiclav are really the two key antibiotics that we need to address. So they are seeing mostly amoxicillin, trimethoprim, furantoin. And you'll know now that the urinary tract guidelines and the therapeutic guidelines have demoted cefalexin and promoted trimethoprim, furantoin as sort of the first-line antimicrobials. Still very high numbers of patients being prescribed antibiotics. And this data from ACNAPS has actually really been important, and Nolene has been an incredible driver for action. Actually, she's remarkable, to the point that ACNAPS has been mandatory in Victoria in 2018. We are still seeing rapid adoption of ACNAPS, that there has been directed funding for AMS in aged care. We continue to do important work by Leslie in the bioethics issues around end-of-life prescribing, and now the Commission Aged Care, which we have a submission, and we'll see how that goes. So this is some of the work done by Leslie Dawson, who's here this morning, looking at issues around how we can look at end-of-life prescribing. And this concept, nurses are conductors of antibiotic decisions, I would stop there. I think that applies to all patients in, perhaps not in general practice, but certainly in hospitals, and certainly in aged care. Nurses are the conductors of care, period, and they could have a very significant role in who and what could be done around antibiotics, particularly in terms of stopping IV oral switch, ensuring the patient understands why they're on an antibiotic and really understanding the need for it. And there are serious issues around the professional consequences. Fear is a key area about what to do, and these nurses probably face quite a bit of pressure in this space. There have been some really great national programs around the management of UTIs in aged care, which is clearly what we consider, we call it the low-hanging fruit. So the NHS had one where they had decision aids. This is a Canadian one, symptom-free P, let it be, and the French one is actually quite cool. I can't remember what it is now because I can't speak French. But this has actually been a very popular program, and this is definitely something that NCAS really needs to be driving into our aged care homes, looking at a program around management of UTIs. The US do have something which did make it in under the bar just before Trump got in, as opposed to the hospital one. So this is their core elements of stewardship for nursing homes. And it is fair to say that there's actually been some quite impressive action in the US around putting it in. So general practice. Well, this is where I think potentially we could say that Australia perhaps are laggards in this space. And some of it relates to the fact, I think, that the UK have the NHS, which really creates that trust environment where they can influence prescribing in general practice that we simply can't do in the Australian healthcare system. And they also have had, Dame Sally Davies is finished her term now, but she was an amazing leader in terms of AMS and AMR, and really demonstrated in very, very impressive global leadership. And one of her first actions was to write to GPs in the UK and to let those that were in the high prescribing bracket know that they were over-prescribing, which definitely showed an impact. It wasn't sustained, but it was really the first time that the Chief Medical Officer had done such a nudge action. And they also have this open access to their data. This is not something which we do in Australia where we can log on, well, not even log on actually, we just hop onto their website and you can run reports of how the volume of use in your own GP area, benchmark and see who are high users and low users. This is really something I think that we know is required moving forward, that transparency and ability to see what's going on in your sector and high performers and low performers. They also have a fantastic toolkit actually, and these are all freely accessed in in the UK. Everything's freely accessed. I think that's really important. A lot of what we have in Australia is behind logins and firewalls, and it's just really not open and easy to get. And that means that a lot of people don't realise that there are actually quite good resources out there, but they just don't know how to find them or can access them. So our Chief Medical Officer also did a nudge. And it was interesting, you know, this was how it was presented at the meeting, castigated for over-prescribing antibiotics. And it's amusing when you hear him talk about some of the letters he got back. But it really actually was quite an effective intervention. Again, short-lived, but he also sent out a letter to those some higher prescribing general practices. And here you can see if the letter compared to peer comparison was much more effective. If they included a graph, it was even more effective in reducing prescribing. And so this again brings into play this concept of nudges, how it can continue to change or improve prescribing using nudges in general practice. We have to also reflect back, just like in hospital systems where it has taken almost 20 years to get to where we are in our hospital stewardship. Harkin Harnberger here, who came out to meet us a few years ago, also gave us a reality check. The Swedish drama program is amazing. It really did start, and it's focused on general practice. It is One Health now, but it really was amazing to hear his story. But he reminded us that it did actually take a long time, and just like in Australia, it started with a group of interested experts and how they started to garner funding and government support to build a proper program. And they were able to demonstrate very significant reductions in usage in the population. And some of the key elements of success were they did set a national target, they did define indicators, and they did provide quality feedback. And that's a graph to show how they've continued to fall. In fact, it has fallen so much that they then went on to say, oh, look, we better look to see if there's actually unintended consequences for under-prescribing. So they look to see whether there are increased rates of mastoiditis or sepsis that were due to very, very low rates of antimicrobial prescribing. And the lessons that we learned, or I think we need to look at, is, first of all, that there was commitment and they were able to get sustainable funding from the government. So rather than lurching from year-to-year budgets or year-to-year blocks of funding to do surveys, there is a sustained funded program, and that this absence of diagnosis, which we know is a significant issue from the data out of general practice systems, you know, when we did our GP NAPS audit, the diagnosis was only in there with the prescription 18% of the time. It's incredible. How can we actually do qualitative audits when we don't know why they're giving the antibiotic? They do compare the guidelines, they give local individual feedback. They have set these targets. The surveillance is now mandatory. So I reminded you before that a lot of our surveillance currently is actually voluntary. It's not mandatory. And that we need to closely integrate infection prevention with AMS. And the other thing is that they have actually had good communication strategies and toolkits. And when you look at what they actually give the GPs, it's not a big fat book or a complex website. It's these really simple checklists on the recommended antibiotic for this particular condition. It's really not complex. Australia, there was some funding provided to the group in Queensland, Mignon Avent and David Patterson, Mika Van Drill's group, to look at how can we look at elements that were demonstrated individually in systematic reviews to improve prescribing in general practice. What if we put those together as a bundle to demonstrate improved practice? This was a very ambitious project. They only had something like 6 months or something to do it and complete it. So I think they were sort of stymied a bit by the time course and the challenges in actually getting this up. But they had practice posters, pamphlets, delayed prescribing, access to CRPs and decision aids, and were able to demonstrate a fall. But really, again, another sort of projectitis symptom where you have a defined thing without a sustained extension, future focus, and I think that's really disappointing. What about, this is something our group's very interested in, how can we improve prescribing in the point of care by providing some decision support at the time of prescribing? And there was a big very impressive cluster randomised study. The UK are really good at doing cluster randomised studies, and I think it's because of the NHS trust thing, I think. But anyway, it's really 79 practices. And they were able to demonstrate that by having some webinars and prescribing feedback reports and some decision support tools, they were definitely able to improve it in adults, but really it is an issue again for children, where there are often other factors driving prescribing, and then very old people. These are possibly in aged care homes where the GPs are visiting. Our own team, our animal stream, are actually doing a cluster randomised study in veterinary practices, which is really exciting and will really be a world first. So it'll be interesting to see how that goes. This is some interesting data. I find this actually fascinating, looking at guideline compliance in general practices, and this required a manual audit with our team going in and using the NAPs to look at compliance and non-compliance. And what was actually incredible, which is really a structural issue, is that they were able to show that actual TG compliance was only 21%. But if you look at MIMS, which is actually embedded in their prescribing programs, they were going to MIMS to look at dosing and choosing MIMS indications for dosing and choices, you actually saw 85% compliance with MIMS. MIMS is product information. It is not clinical guidelines. So it's shocking, isn't it? And so here is a very simple indicator of what we need to be doing to be supporting our general practitioners. They need to have access to therapeutic guidelines in a meaningful way at the point of care, rather than having to go to a product information program, which is really used by us for looking at sort of toxicities and other contraindications for prescribing. And this is some of the areas where there was really poor usage, upper respiratory tract infections. There was lots of dosing confusion, particularly across different age ranges, and we've seen that in the paediatric NAPs. A lot of use of augmentin and cefalexin. A lot of durations are driven by pack sizes rather than actual days required. And then there was this concept of repeat scripts, and you might have seen there was a newspaper article in the Australian yesterday saying that government's cracking down on antibiotics, and that is because there has been a review of automated repeats or approved repeats for many more antibiotics. So they will actually be largely removed, which means that the practice software systems will also need to have a zero repeat against particular antibiotics. And I think that probably will have quite a significant impact. The other thing is the accreditation standards for stewardship in our College of General Practice is actually very weakly worded, and it's a little disappointing. So they have suggested activities rather than a framework, a systematic framework around stewardship. So it's a suggestion to use therapeutic guidelines and a suggestion to use patient and a suggestion to use developed practice and policies, but it really doesn't kind of, I think, meaningfully say what needs to be doing. So these are some of the areas that we know I mentioned earlier that we need to be doing to improve prescribing. So finally, companion animals, just a few slides, but the animal sector has put out their resistance plan, and I think it's fair to say that the position is actually quite good in terms of their volume of prescribing, but they are really anxious about this, how they present their prescribing to the community and how they present their data. And one of their key statements is that they want to be well positioned to address this perception by demonstrating and promoting appropriate use of antimicrobials and antimicrobial stewardship activities. And this is really where we're at now. So how do we actually demonstrate this appropriate use? Because we don't know. There is no publicly available data on appropriateness of use particularly in the livestock space. But we know that our usage is actually very low internationally. We don't use growth promoters. Use is tightly regulated, particularly around the labels. We do not use antimicrobes of critical importance. We have very different opportunities in terms of livestock farming because of our space. And we don't, and as I mentioned before, we need more data. We also know that the single species where we know many of the efforts need to be addressed is in the pig industry, where it is more intensive and pigs get sick. Animals do need antibiotics, but this is one area where it'd be good to have more information. Something that I learned, which I found incredibly fascinating when I first started working with the animal stream, is that because of the strict legislation around how antimicrobials are used, particularly in the livestock area, it's very much defined by what's allowed on the label. And so that has meant that very old 30-year-old labels are leading to underdosing of antibiotics, particularly penicillin, cotrimoxazole, gentamicin in horses, and that the doses provided actually determined the washout period so that the meat can be safe for consumption. In the veterinary space, off-label use is very, very common. It's also very difficult and expensive to get microbiology for animals. We can't have the same sort of clinical care standards for animals as we have for humans, where we are expecting to have micro done before an antibiotic is given for a sick human being. It's complex and sometimes difficult. And so this is a issue that needs to be addressed at a very high legislative level to improve quality of use because of the limitations of label and the issues around off-label use. And this was one of the slides from Helen Crabb, who I'm sure many of you have seen, showing that we actually use this antibiotics in our companion animals compared to our humans. And there have been many important first-off publications around quality of use, particularly in surgical prophylaxis. These were the first ever surveys in Australia and have driven the development of appropriate guidelines and establishment of stewardship programs. And the other thing which I always have found it very interesting, which I'm sure you've heard me say before, is the difference between use of long-acting injectable antimicrobials, the cefepime, in cats compared to dogs. And the only thing the vets have said to me is, well, have you ever tried to give tablets to cats? So I don't know if there's a solution to that, Kirsten and Glenn. But it's a very interesting and funny anecdote. So it is early days, but we are certainly moving forward to establish these toolkits and resources and really look at the feasibility and implementation of these programs, particularly in the veterinary companion sector, and a bit more of a challenge in establishing a framework in the livestock space. So my final slide, and I've no idea of the time, so I'm sorry if I've gone over, Arjun, I don't have my watch on, is, look, overall I think we can say that we are leaders. We do really have incredible opportunities for training, tools, people and track records for innovation implementation. And I think we need to keep moving forward and pushing the boundaries, particularly in areas like general practice aged care and in the animal sector. I'll leave it there. No, I did. Oh, is it? Not there. I think there's people waiting to come in, so I can't take... this is no questions today, thank you.